Welcome to The Whole Pineapple. I'm Ruby Boris.
And I'm Ann Judge. The Whole Pineapple is a podcast about wellness focused around fertility. And on these weekly mini episodes, we bring you bite-sized ideas for you to snack on.
Like breathing exercises, book reviews. Maybe we'll review some scientific research, or we'll share some wellness and fertility stories from our listeners.
So if you're looking for a tip or a trick related to your fertility and well-being, then you've come to the right place.
Let's dig in.
Well, hello, Whole Pineapple. We are so happy to welcome back to the podcast Dr. Lora Shahine. She is, we had her whole long bio in the full episode, but just a colleague of ours in the Seattle area who has done such good work, all different areas of reproductive medicine, but especially related to pregnancy loss and recurrent miscarriage. And we focused a lot in our main episode on testing and treatment options for the person trying to get pregnant. And so we are happy to welcome her back today to talk a little bit about what we know in terms of the sperm health side. So welcome back to the podcast, Dr. Shahine.
Thank you. I'm happy to be here.
And I mean, you just hop right in. Like, what do we know? Do we know anything about sperm and miscarriage? Or
in my book, Not Broken, which is all about miscarriage, I have a whole chapter on the other half, men and miscarriage. And it's the shortest chapter.
Oh, I know.
And it's not fair. It's a part of history. It's a part of research bias. It's a lot. But the sperm is half of the genetic equation. So they make a huge difference because we really believe the most common cause of miscarriage has to do with the embryo, not the person that's getting pregnant. And so we want to be able to figure out how sperm is contributing to this and be able to do testing. But because so much of bias on anything that has to do with reproduction is so female focused, research, testing, treatments have all been female focused. It's starting to change, but we need to learn more.
Sperm are so abundant and so much easier to access than eggs.
And I feel like often, even if someone's had recurrent miscarriage, if they check a semen analysis and it's normal, that's kind of like the end of the conversation. But it really shouldn't be. I guess the challenge is we're still limited in kind of the other testing that we can do. So are there things when you're taking a history that make you feel more concerned that there might be a factor on that sperm side, or?
I mean, the one test that both partners should do is a blood test for a karyotype. People kind of forget about that, but the male partner should also get that blood test. It's looking for a very rare cause of recurrent miscarriage, but you don't want to miss it. It's called a balanced translocation. If the partner has a balanced translocation, it just means there's a little rearrangement between two of the chromosomes, and it's in all of the cells in the body. And I try to reassure the person that's getting tested, like, hey, if this comes back that you have a balanced translocation, it doesn't impact your health. You're fine. But it means that a lot of your sperm is going to be missing information because every time you make a sperm, the chromosomes have to split apart again. And if that's the case, then not all of your sperm is going to be affected, but it could really explain why you as a young couple maybe are having a lot more miscarriages than you would expect. So one way that I sort of get a little clue as to maybe if that's the case for a couple when I'm just chatting at that first visit is tell me about your family history. Like, does anybody in the family have miscarriages or difficulty conceiving? And sometimes one of the partners will say, oh yeah, my grandmother had 10 miscarriages or my sister has had miscarriages, because you can actually pass a balanced translocation through the family because people can still get pregnant. Not all the sperm is affected. Not all the eggs are affected. So it's not always the case, but sometimes I can sort of pick up like, oh, I wonder, like this might be there.
It's also always good to ask about prior partners because we forget a lot of people are coming in. This may not be their first time trying to cause a pregnancy. And sometimes they'll mention, oh, well, yeah, my ex-wife and I, like we tried and we had a few miscarriages and then we stopped trying. We didn't do any testing, but now I'm with this partner. So I'm sure that also makes you a little suspicious for something.
Yeah. And oftentimes I think there are a lot of partners that say, please test me. Like, look at my female partner and all
the things
stuff,
she's going through.
All these tubes of blood you're taking from her. Like, please test me. And so I just say, listen, I do want to do a karyotype. That's kind of the one blood test. And then I do think it's important to do a semen analysis, but I want to be really clear. There's nothing on a semen analysis that's going to tell us why you're miscarrying. The reason I'm doing a semen analysis is I want to look and make sure that there's not another fertility issue. Because sometimes you'll find kind of borderline sperm counts, or you'll ask patients and they're taking, 6 months to a year to get pregnant, and then they'll have a miscarriage. So in the history, you just don't want to miss, another issue other than miscarriages. And so sometimes with the semen analysis, it's just also kind of like a baseline. And if it's very reassuring, it's like, okay, we've got this. But that doesn't mean that I might not see the couple a year or two from now for baby number 2 or something like that. And then we do a semen analysis and it might have changed. And I'm like, okay, we have this data point. So that's helpful. A lot of patients ask for DNA fragmentation testing.
That was going to be my question.
We're on the same page.
Natural segue. So DNA fragmentation testing, it's just not the test that we want it to be. Okay. We're all looking for ways to figure out if the sperm is going to be okay or not. And what it's doing is you have to destroy the sperm in order to see if there's fragmented DNA inside the sperm. In general, the thought is if there's a lot of fragmented DNA, then that might impact somebody's fertility, or not all the sperm is going to be perfect, or maybe it might increase the risk of miscarriage. And there have been some studies that sort of suggest this. And I'm like, okay, but the issue is every sperm sample is different. And in a lot of tests or studies where they're really trying to see the accuracy and the reproducibility of DNA fragmentation testing, they could do 5 tests in a week and they could get drastically different results. So just to assume that this one time where there's a really poor sample is going to reflect everything is kind of hard. And then also you kind of think, well, if you see it, what are you going to do about it?
That's what I would say. What are you going to do? Are you going to use donor sperm instead? Like, do you want to continue your genetics for the parenting? Because you're not going to pick the sperm any differently based on the results you get usually.
Sometimes people say, oh, well, then maybe I would do IVF, because there are ways to use gradients that do pick out sperm with lower DNA fragmentation, or sometimes they talk about donor sperm. But I also just sort of say, like, listen, it could be that, the very next time you guys try, it just happens to be a perfect sperm. It doesn't mean all the sperm is bad with a high DNA fragmentation. So again, I appreciate it. And I wish that the test was there to help with intervention. Sometimes you can use the semen analysis, or if they ask for a DNA fragmentation test, which I don't order very often, it can be a springboard to talk about lifestyle optimization. In general, the person who's getting pregnant already feels like under a microscope, and I've been watching my diet and I haven't drunk alcohol in a year and I've cut out caffeine, and like, how many more things do I have to restrict from myself? And then in general, this is by far every patient and every couple is completely unique. But a lot of times people might say, oh, well, my sperm count's fine, therefore, I don't have to change anything. But it could be like, hey.
Yeah, you're sitting there drinking wine while you watch your partner. Like
Exactly. And it'd be like, hey, let's talk about, are you smoking? Are you vaping? Are you in a hot tub every day? Like, are there things that we could optimize? Are you eating well? So it can be sort of a springboard into talking about overall health.
We talk about so much about age on the egg health side. What do you say when people ask you about age and sperm and rates of miscarriage?
Well, there's definitely the myth or the feeling that men can cause a pregnancy at any age, but most men are not Mick Jagger or Charlie Chaplin. So sperm counts do go down. Sperm function does go down with age. And then honestly, but it's just not as dramatic compared with eggs and sperm. Like eggs, it's very dramatic and it happens at a much younger age. With sperm, there's so many sperm to choose from, and you just got to have one lucky one. But the other thing is especially over the age of 50 and then incrementally, like past 60, past 70, there are some issues that come up. There's a slightly higher chance of autism. There's a slightly higher chance of some genetic issues that might occur, lower functioning of the sperm. And it doesn't mean that you don't try to conceive with sperm that's over 50, or that you have to do a different intervention, or you like have to use donor sperm. But it's important to talk about that there could be a age factor increasing the risk of miscarriage as well. It's just hard to pinpoint.
And it's so hard to study because often you're not able to control for the age of the other partner either. So often if you're talking about, someone's in their 50s, their partner's often in their 40s. And so it's very hard to figure out how much is coming from either side.
Yes, exactly.
And one final question I have is for those that are using donor sperm and have had a miscarriage or 2 miscarriages, Where this is recently, just I had a patient that had this happen. What do you counsel people on that? Do you have to pick a different donor? Like, you can't really do all the recurrent pregnancy loss tests on the donor. So yeah, it's kind of a tricky one.
That's a great question. And I do talk to people who are using donor sperm where either if they're not conceiving or they have had losses, you have the ability of switching out that variable.
Mm-hmm.
And I have no idea if it's going to make a difference or a change, but sometimes just starting with a fresh start, starting with a new donor can be an option. And it's just a discussion point, but it's not like if somebody is having miscarriages with the partner that they want to have a baby with, we say, oh, go divorce and
Right.
get a new partner. So it's something to discuss, and patients do ask me about it. I'm like, hey, it's something that we could do, but I can't prove, or there's no evidence to say like, yes, switch out the sperm source. So good question, but hard to say.
Yeah, I should know this, but do you happen to know if the donor banks, so people that are using an agency for their donor sperm, do they do karyotyping as initial screening? I feel like they don't.
It is not necessarily recommended by the FDA like certain other tests are or expected. There are some sperm banks that do it, but it's not standard.
All right. That was a run through of the sperm side of things, just like the research.
I just say, just like everything else, sperm get the short amount of time.
Oh, poor sperm. They're so cute looking though.
I know.
Yes.
I know.
Hopefully you can flesh out your book later, right? Like if they get more research, if we find something out on the sperm side, you can make that chapter longer.
Next edition.
Exactly.
Anniversary edition.
I hadn't said this yet, but the second edition was recently published just this month.
That's awesome.
The first published in 2017, and then there was so much to catch up on with ASRM changing the definition of recurrent miscarriage to 2 instead of 3, and taking out the word clinical from that really strict definition and trying to use more inclusive language. And I did look for more information on sperm, and nothing's changed in 5 years. We need more research, need more data.
All right. Well, that's a call to the researchers to work on that. And you can find Lora on all the social things, and it's at Dr. Lora Shahine. Where else can we find you?
Yes, my website, drlorashahine.com. You can find the book, Not Broken, the second edition, the most recent edition on Amazon. Thank you.
New and improved. That's exciting.
Yes. And I just really appreciate being here, you guys, and talking about something that's near and dear to my heart. And, just really appreciate this opportunity.
Thank you so much for your time. Thanks for joining us for this week's episode of the Whole Pineapple Podcast. We hope it was helpful.
If you know someone who could benefit from hearing the podcast, we hope you'll share it with them.
And don't forget to subscribe, rate, and review The Whole Pineapple on your favorite podcast app. Every rating and review makes us easier to find.
This podcast is sponsored by Seattle Reproductive Medicine and is produced by Audiotocracy Podcast Production. We'll see you next time. Have a delicious week.